I come from South Africa, as you've heard. This is the country that brought you Nelson Mandela and apartheid. So, interesting place. Modern constitutional democracy, beautiful country. If you ever get a chance, come past, come spend your time, and more importantly, come spend your dollars. What's that? It's a big 5. Ring a bell? One of them is missing. Which one's missing? Rhino is missing. Rhino is missing because if you don't go and see a rhino in the next 10 years, you will not see them. They're being exterminated at a rapid rate. They are nearing extinction, and that's because some people believe that rhino horn, which is keratin, it's the same stuff that's in your nails, can actually give you libido. So please, if you want to see rhinos, bring your family, come and see them before they're all gone. Right, this is where I work on a lighter note. I work in a fully private practice. We have level 1 trauma centers with things like pediatric oncology and everything in our private sector. So it's a bit different from what you guys are used to in the UK. I work at 2 hospitals, these two facilities, and as you can see, at least from the outside, they look pretty impressive. This is where I do most of my work. Bottom left is in the operating room. Occasionally I'm lucky enough to go out in the bush and operate on animals with one of my veterinarian friends, and then we literally operate in t-shirts out in the bush, which is fantastic. Incidentally, I left in the middle of winter. I arrived here in the middle of summer, and the temperature didn't change 1 single degree. It was exactly the same. So that also was quite interesting to me. Anyway, I was tasked with giving you a talk about this, biomaterials, antibiotic delivery systems, and irrigation techniques. Now, you and I know that it's impossible to do that in 20 minutes, especially since I've spent about 5 minutes introducing myself. So we're going to basically zone in on a few specific aspects, and what I'm going to share with you is a little bit of the experience we've gained in using one of these techniques over the last 10 years or so. So we're going to make it very practical, and we're going to zone into a very pragmatic type of approach. Osteomyelitis, we can spend a lot of time on. What we're talking about here is not acute hematogenic osteomyelitis. What we're talking about is, let's call it post-traumatic chronic osteomyelitis, for lack of a better term. Treatment strategy for that type of osteomyelitis or bone infection revolves around 5 central pillars. Of which debridement and obtaining proper tissue for culture is probably the most important one. Secondly, goal-directed therapy, and this is where the antibiotics come into play, and we can have long discussions later tonight over a beer whether antibiotics have a role to play systemically, but we can do that later. Then dead space management is extremely important. That goes hand in hand with the debridement techniques, as do soft tissue reconstructions and eventually bone reconstruction, because once we've been in there, ripped out all the infected bone and tissue, there's often big gaping holes that we need to fill again. Biomaterials come into play in those 3 instances, helping us with goal-directed therapy, in other words, in antibiotic delivery, helping us with dead space management, and helping us with bone reconstruction. And this is really where I see the place for biomaterials in treatment of osteomyelitis. Right, so we've said that the most important functions in osteomyelitis for biomaterials would be dead space management, and that's fairly obvious. You're putting a piece of cement in there, or putting your calcium sulfate, calcium phosphate pellets, or your gentamicin beads, whatever you're using, you use to actually occlude the dead space that you've created after your debridement. So that's one important function of a biomaterial in this context. The second one is antibiotic delivery, and here we can also have a long argument over a beer about how effective this really is, because we know that the antibiotic elution only happens for the first couple of days, and then after that it drops down tremendously. So effective antibiotic delivery through biomaterials is probably a little bit of a pie in the sky idea at this stage in its current form, unless we can somehow get a delayed release of antibiotics by encapsulating them in microspheres or doing something fancy to them. But in the current form, cement block spacers, calcium sulfate with antibiotics, all of these things would have a limited effect in terms of delivery of antibiotics. It can give a high dose locally, but for a short period of time. Maybe that's all we need. Right, and then lastly, the biomaterials are often used as adjuncts to your bone grafts and that sort of thing in order to constitute for bone defects and try and regrow pieces of bone. So either osteoconduction or osteoinduction where it's used. The most commonly used ones that we have at the moment, I mean, there are many more, and it all depends on how you define a biomaterial, but the ones that are probably pretty commonly used are calcium sulfate, calcium phosphate, different preparations, different types of ways in which we can do that, either pellets or cements or little blocks, whatever blows your hair back. The ones that I almost exclusively used, the one I almost exclusively use is PMMA. Which is basically the grout they use to stick arthroplasties to the bone. And obviously they're quite useful in the sense that they're quite rigid, and they've got this fantastic ability to induce a pseudo-periosteum if you actually put them into a bone defect. This is what most of us know as the masculate technique, where if you put the PMMA in there and you leave it for a while, it actually makes a beautiful membrane that is actually bioactive. That membrane is active, and you can then use that to your advantage once you want to go and do bone reconstruction through bone transport through that segment or using that as a bed for your bone graft. It's quite effective in antibiotic delivery, but only for about 5 to 7 days. After that, the elution drops down quite tremendously. Right, and then bioglass, I think, is something it's a pendulum that's swinging. It was in vogue about 20 years ago, and it's probably going to come back into vogue again, specifically in the treatment of osteomyelitis, because it has antimicrobial properties, but it also has osteoinductive and conductive properties. So it is seen in some circles as the panacea, as the solution for osteomyelitis. I don't know if I agree yet, but that's something to watch. Incidentally, plexiglass that they put on the spacecrafts and things is also a form of PMMA. Our PMMA is just not as sexy as the one there in the picture, unfortunately. Would be fantastic if we played with PMMA that looked like that, eh? All right, so basically the two that I think we can link ourselves to at this stage in current practice as it stands now is these two. Where the PMMA is used extensively as cement block spacers and also for antibiotic nails and also for joint spacers and stage joint arthroplasty revisions. So these are custom-made molds that you then mold an arthroplasty with. As you can hear, I'm not a big arthroplasty surgeon. I prefer not to do internal amputations. Anyway, bioactive glass is the other one that we spoke about, which is basically osteoconductive and also can provide local infection control. So I think watch the space. This is where a lot of new development is going to happen in the next couple of years. All right, so that is biomaterials in a nutshell. We're going to go across to antibiotic delivery, and we've touched on it somewhat, but we're going to go into a little bit more detail. Now, in my mind, I cannot really separate antibiotic delivery and irrigation techniques from each other. Maybe it is because I'm from South Africa, where Lautenbach was from, so we have a irrigation bias, I guess, if you want to call it that. So in my mind, these are very similar things. I think the way that I use cement block spacers is really there for the benefit of the induced membrane rather than the benefit of the antibiotics. Incidentally, if you want a great membrane, let the cement harden inside the soft tissue. I know it goes up to 80 degrees. I know it causes thermal necrosis. I think a lot of the good quality membranes we see, the pseudoperiosteum, actually gets induced because of the temperature. So just don't tell your plastic surgeon that. All right, so irrigation systems. A talk about this would not be complete without giving a nod to Professor Lautenbach. This picture was taken 2 years ago when he was 81 years old. He still runs 3 lists a week. He still operates on those lists for 10, 12, 14 hours a day. He does operations that last 4 or 5 hours. This is a machine of a man and a real giant in orthopedic infection. If you do get the chance to come out to South Africa, do so before he passes on. He's really a wonderful gentleman and a great guy to spend time with. Wonderful teacher as well. He's, interestingly enough, also an active orienteer. He does orienteering, which is where you basically take a map and a compass and you follow instructions and go off into the wild areas and do basically on instructions you find things and so on. So he's a great fan of that as well. In his young days, he traveled to Antarctica, to the South Pole, to go and pay for his studies. He also worked as a miner for some period of time as a student to try and get himself through medical school. So a very, very interesting man, real gentle giant and fantastic thinker. So he came up with this system in the 70s of basically using local antibiotic treatment. That's basically what it boils down to. He uses a very specific way of doing that. It's a double lumen system where you've got an inner lumen and an outer lumen, and through the one you instill antibiotics, through the other one you let it drain out of the limb again. And it's intermittent, so that's pretty important. This system is intermittent antibiotic delivery. The antibiotics are given in a very high concentration and a very high dosage. Because it's given locally, we can get away without worrying about systemic effects to a large extent. And it's low volume. It's really ridiculously low volumes that he instills, leaves there, and during the next treatment, 4 to 6 hours later, he then lets that fluid run out again. He measures the amount of fluid, he samples it microbiologically, in other words, he sends it to the lab to culture it. And once you get clean fluid back for 3 consecutive cultures, then you know you've cleared up the infection. He talks often of curing infection. And I must say, it's true, but it's also not true. The other interesting thing is the volume. If you measure the volume of fluid that you get back, he's adamant that you're actually measuring the cavity, the size of the cavity indirectly, and that you're actually measuring the dead space, and you're managing the dead space actively by actually sampling this fluid and checking the amount of fluid that you can instill and get out. So that's his technique. Now, for those of you who've tried it, I think all of us will concede that unless your surname is Lautenbach, it is very, very difficult to actually manage this practically in a busy clinic day to day, because it is so labor intensive. And unless you have nurses that have worked with you for 50 years, like it is in his case, it is technically very, very difficult to execute in a busy practice. I'm not saying it's impossible, but it is very demanding. So for most of us mere mortals, we modify the technique somewhat, and we'll get back to that now. I think fundamentally we have to understand that this is not an irrigation technique. This is a technique that has irrigation as part of its treatment. The treatment, the full treatment, is called DRI: debridement, reaming, and irrigation. And those 3 pillars are extremely important. And you cannot do the one without the other. So fundamental to the success of this technique is being able and being willing and being inclined to do a massive debridement, even if it does take you 3 or 4 hours. Secondly, reaming the bone from end to end, literally from joint to joint, is what is fundamentally important in this technique. And then lastly, the irrigation technique. So those 3 steps, those 3 pillars are essential in making this successful. The reaming is important because he's looked at these numbers, and he's looked at bone infection probably more than many people in the world. And what he's found is that in 2/3, about 66%, depending on the site, but about 2/3 of the cases, you would find infection in one part of the bone and what he would call a sump infection in a different part of the bone. So you would, for example, have an infected pilon fracture distally in the tibia, but if you sampled the proximal tibia, you would find positive cultures from there. And this is the rationale or the reasoning behind end-to-end reaming of the bone, so that you can eliminate these sump infections. If you do this, then you probably do not need 6 weeks of antibiotics post-treatment, because that's probably what that antibiotic is for, is to treat the sump infection. Because the sump infection is closer, in my mind, to something like hematogenous osteomyelitis that you can treat. It's a marrow distant site, almost like hematogenous in a young child. So sump infections, just bear that in mind. If you believe that, then you need to ream the whole canal out every single time. All right, then fundamentally, local antibiotic delivery and dead space management, extremely important here. And then continuous microbiological surveillance so that we can give goal-directed therapy. The beauty of this is you can change what's in your bag every single time, depending on what you're culturing and what your organisms are doing. Remember, they're sitting in there, and if you've missed a few of them, they're sitting there in their little jelly matrix, quorum sensing with each other, talking to each other, and creating all these wonderful packets of resistance. And unless we are on top of them and ahead of them, then you run into these carbapenem-resistant intrabacteria, etc., the VIM organisms that all the critical care specialists hate. Interestingly, group of orthopedic surgeons, who knows what that acronym stands for? VIM, V-I-M. Anybody? Help me out here, guys. We need to impress the infectious disease guy. It's Verona integrin metalloproteinase. So it's a specific mutation that has a very specific beta-lactamase in broad terms that makes these organisms resistant to every single thing we have to throw at them, except stainless steel. All right, so we've modified the Lautenbach technique and we've refined it over the last 10 years or so and used it in a number of cases. We're busy writing that up, so I didn't want to bore you with the statistics. But our modification is basically a continuous system. So it's a closed continuous system, so it's not intermittent, and that takes away 4 times a day of having to be in the ward. All right, so I can still do my once-a-day ward round and still make the system work. All right. Secondly, it's high flow. And it's connected to negative pressure, so it's a closed suction system that runs on a negative pressure basis the whole time. High volumes, roughly 3 liters per 24 hours, and then lower dosages of antibiotics. Because we're running higher volumes through there, we can probably deal with lower concentrations in the solution. All right. This is not new. This is something that many people have done before. This is just the way we've modified it. So that is something that screams irrigation to me. That's an infected nail in a distal, well, what's left of a tibia and an ankle. MRSA positive. He's got a zoo of gram negatives in there as well, and he's draining copious amounts of pus. So this is the type of person where DRI is a good technique to use. In addition, he's a poor host. He's a diabetic. He's on gout treatments and all kinds of other things. So he happens to be a smoker as well. Right, so step 1 in our technique is removal of all the implants, proper debridement locally from the outside, and then reaming the bone end to end, obtaining adequate number of specimens, 5, 6, 7, 8 specimens, send them for extended culture. If you've got clear pus, put them in the Bactec bottles, the whole story. Lavage. At this point, we then employ a pulse lavage, and we actually rinse through that canal completely. Before we get there, how do we ream this? We ream this with the standard reamers that we use to insert locking nails. So sequential reaming, if you start with an implant that you take out that's 8 millimeters, you would start at 9 and then go up in 0.5 millimeter increments. Until you get a good amount of clatter. And then we go with the RIA system, the suction irrigation system, and we ream once more with 0.5 millimeter larger. So we end with the RIA reamer. You will know that the RIA reamers, they open for you per reamer head, so you don't have the luxury of sequentially sizing them up. So we end with the largest one, and you're sucking as you are reaming. I think that's important. I think that's important because otherwise your reamers, many of your reamers, actually shove the reamings down into the sump area again, unless you're sucking on that reamer the whole time. Well, not you, the system needs to be sucking on the reamer. All right, and then you need to stabilize the bone. If the bone is not united, it's a good idea at this point to either use a back slab or a temporary X-fix. We tend to use temporary external fixation at this point, and that can be circular, monolateral, modular, whatever gives you the basic stability you need. Remember, stability is critically important in the control of infection, as it is in bone union. Right, so that's the first step, is sort of the cleaning step. Then we re-glove, re-drape, clean, and then we insert our irrigation pipes. Irrigation pipes are really just a portavac, so a suction drain with perforations all around the length. We use the 1/8 inch diameter, and we basically put that in the medullary canal. Now there's a trick here. It's not a single tube that we use. We use an in tube and an out tube. So we cut it in half and put one from the top and one from the bottom. If you use a single tube, as time goes on, those little perforations clog up and your fluid just goes from top to bottom and doesn't go out into the bone. So you have to have two separate tubes that connect by virtue of the fact that they're located in the same space. So the one will suck and the one will blow, but they are separated from each other in the medullary canal. We then suture them top and bottom. This is the only time when we actually do suture our drains, and they go out through a separate hole, not the same hole that you used for reaming. So we make a little skin breach, and then we bring the tube out through a secondary hole. All right, and then the interesting bit is how to connect this up to your fluid and to your wall suction, because that's what you inevitably want to do. Now, if you took your tube out there from the side of the little concertina thing, that actually fits onto a wall suction quite nicely. The other end also fits onto a cysto set that they use for bladder irrigation and urology. So that actually fits onto that connection quite easily. Anyway, you'll have to play with your plumbing to see what works the best for you. Point is, it's a closed system. On the one side, you've got the bag of fluid that runs into the bone. On the other side, you've got a pipe that runs out of the bone and goes to the wall suction, and the suction is set on a medium amount. The beauty of this, it also anchors the patient to the bed so that they cannot go and smoke. So this is a fantastic way of cessation of smoking. All right, and then what do we put in the bag? It's basically a solution of saline with 5,000 units of heparin per liter. And then I put in there always rifampicin and gentamicin as a minimum. And then we add some other antibiotics to it, depending on the culture and sensitivity results. Rifampicin and the gentamicin I put in the same amount per bag is what I would normally have given IV. So, for example, I would give 240 milligrams gentamicin daily IV as an IV dose. So I would put 240 milligrams in my bag. It's a fairly low dose, and that would be interesting to have a chat with you about that, because it's probably a little bit too low, and we are a bit worried about antibiotic pressure for the organisms. Rifampicin, for example, we would normally give 300 milligrams a day, so that means there's 300 milligrams that goes into a single bag. If we were to give cefazolin, for example, we would give 6 grams per day, so that would be 6 grams that goes into a single bag. Remember, a single bag runs for about 8 hours. We run about 3 bags per 24 hours. So in the end, we're getting 3 times what we would have gotten IV as the dosage that irrigates through. I think there's a big factor of mechanical cleaning also. It's not just the antibiotics. I think it's also that high flow, high volume that pushes through the whole time. And then a lot of that diffuses out into the tissues. It works beautifully for soft tissue wounds as well, soft tissue infection. All right, so the maintenance is now where the nurses have to up their game. And on the one hand, you have the inflow, and on the other hand, you have the out, and they have to balance the two. Otherwise, the bed is wet. So the inflow, generally, we start at 80 mils an hour, which is about the best place to start. And the outflow, we start on a medium wall suction. And then they have to tweak a little bit to balance that. During this time, we then monitor the patients, and we, for lack of something better, we use the CRP levels every 48 hours, and we monitor that until they come down. Now, what we're probably monitoring is the surgical response to trauma rather than the infection, but it makes us feel better. So at least you have to measure something, right? Generally, these things last for about 10 to 14 days, and then the pipes go haywire and you have to pull them, or you have to go and replace them. So they generally don't last longer than about 2 weeks. Then you have to go and replace them if you want to go longer. That's another fundamental difference with Lautenbach's technique. His technique is a longer term technique, 3 to 4 weeks. We're about half of that. Right, and that's where the fun starts. Once you pull your pipes and you've got a non-infected limb, then you're free to throw all the metal you have at it. In our case, we use circular frames for this and reconstruct that limb as you see fit. But now we have a infection that's suppressed, if not gone, and we have a good base to work on. So generally we would pull our pipes, let everything settle down, send the patient home for another 2 to 3 weeks, and then start our bone reconstruction at about 6 weeks. It's completely arbitrary, but that's roughly our protocol. We do use, for the acute phase, we do use intravenous antibiotics. And that's really there to treat the cellulitis and the local infection that we have because of the pus in the area. I really do not sincerely believe that our intravenous antibiotics make any difference to the long-term outcome of the chronic osteomyelitis. Sacrilege, I know, but that's my opinion. I think the local debridement, the reaming, and the irrigation, that is where the key lies if you're going to use this technique. Then I think the need for the long-term antibiotics probably falls away a little bit. Anyway, whether you'll be able to make that fly in your unit, I'm not sure, but that's how we do that. So in summary, I think watch the space for bioactive glass, but PMMA currently still the most useful biomaterial in the use of infection. Think about local antibiotics rather than systemic antibiotics, or a situation of both and that you use both of them. But be judicious about them, use them in the right dosages, right lengths of time. And then consider DRI. I like to use that term rather than the Lautenbach technique because it's more than just irrigation. It's a proper debridement, it's an end-to-end reaming of the bone, and it's the irrigation coupled to that. So those three things go hand in hand. And that is basically the story. Lastly, remember to come and visit us in Africa. Bring your pounds, bring your dollars, bring your euros, but more importantly, come and have a look at the last of the big five. All right, thank you very much. Any questions?